Okay, so today we're diving into rheumatoid arthritis.
Mare.
RA, yeah.
Yeah.
So this is a chronic progressive disease where your immune system attacks the lining of the joints,
The synovium.
the synovium, yeah.
Yeah.
And this is actually fairly common,
It
like
is.
1 in 100 people.
Yeah, about 1% of the population.
Wow.
Yeah. And some populations are even higher.
Oh, really?
Yeah, like the Pima Indians in Arizona.
Interesting.
Yeah.
So it tends to show up, in middle age, and it's more common in women.
That's right.
And so our aim here is to just give you a quick overview and to focus on what's important for surgical practice, especially if you're studying for your board exams.
Yeah, that's right.
Okay, so we know a lot about RA, but we don't know exactly what causes it.
That's right. It's what we call idiopathic.
Idiopathic.
Right. Yeah.
But we know that genetics and the environment both play a role.
Yeah. So there are twin studies showing that identical twins are much more likely to both have RA than fraternal twins.
So that's the genetic link.
Exactly. And one of the big genes is called HLA-DR4.
Okay.
And that's associated with getting RA and also how severe the disease is. Oh,
Interesting.
there are environmental factors, too.
Yeah. What are some of those?
Well, smoking is a big one, and there are some studies that suggest even caffeine might be a factor.
Caffeine.
Yeah, interesting, huh?
Yeah, that is. Okay, so what's actually going on like at the level of the joint?
Right, so in the joint, you've got that lining the synovium, and that's where the inflammatory reaction starts.
Okay.
And it involves all sorts of immune cells, like T cells and B cells and macrophages.
Right.
And all these cells release inflammatory signals that cause damage, not just in the joint, but throughout the body.
So it's like a systemic inflammatory response.
Exactly. Things like TNF-alpha and IL-1 are really important in that.
Side.
And the inflamed synovium also produces enzymes that break down cartilage and bone.
Like little Pac-Man.
Yeah, kind of like that. Things like matrix metalloproteinases and collagenases and cathepsins. And these guys just chew away at the cartilage and bone.
And then you get bone loss, too, from osteoclasts.
Yeah, exactly. All those inflammatory signals ramp up osteoclast activity and they start resorbing bone.
Right.
And ultimately, the inflamed synovium thickens up. It forms this thing called pannus.
Canis.
Yeah, and the pannus erodes the cartilage and the bone and the ligaments around the joint.
So how do you actually diagnose RA?
Right, so you need a good history and physical exam, obviously.
Of course.
And there are specific criteria we use to diagnose RA.
Okay.
You need at least 4 out of 7 criteria, and the first 4 need to have been present for at least 6 weeks.
6 weeks.
Yeah.
Okay, what are the criteria?
So first, you've got morning stiffness in the joints that lasts for more than an hour.
Okay.
Then swelling in 3 or more joints at the same time.
Okay.
And the swelling needs to be symmetrical, meaning it affects both sides of the body.
Right.
And then involvement of the small joints of the hands and wrists.
The specific.
The MCPs, the PIPs, and the wrists.
Okay, and what are the other criteria?
So we've got rheumatoid nodules, which are these firm lumps under the skin.
Okay.
And then a positive blood test for something called rheumatoid factor,
All
right? RF, and then characteristic changes on x-rays.
Okay, so let's talk about those lab tests and x-rays.
So rheumatoid factor, or RF, it's present in many patients with RA.
But not everyone.
Right, some people with RA never have a positive RF, and some people can have a positive RF without having RA.
So it's not perfect.
Nope.
And what about that other antibody you mentioned?
Oh, the anti-CCT antibody.
Anti-CCP.
Yeah, that one is highly specific for RA.
So if you've got that, you've probably got RA.
Yeah, pretty much.
And what about the x-rays? What do you look for?
Well, early on, you might see some thinning of the bone around the joints and some soft tissue swelling.
Okay.
But as the disease progresses, you start to see narrowing of the joint space as the cartilage gets destroyed.
Right.
And then you get these erosions, little bites taken out of the bone.
Erosions.
Yeah, and they tend to happen at the edges of the joint where there's no cartilage to protect the bone.
And is the joint involvement symmetrical on x-ray?
Yeah, usually
Right.
Later on you can see fusion of the wrist bones.
Carpal ankylosis.
Exactly. And then these characteristic deformities like ulnar translocation of the carpus and ulnar deviation of the fingers.
Okay, so let's focus on the hand and wrist now.
Sure.
What are the typical patterns of joint involvement?
Okay, so the wrist and the DRUJ are often involved early on.
The DRG.
The distal radial leaner joint.
Right, okay.
So you might see changes in the scaphoid and the lunate and the ulnar styloid
Okay.
and in the DRUJ itself.
Right.
And then later, the radiocarpal and midcarpal joints get involved.
With erosions.
Yeah, you can see erosions on the palmar side of the radius.
Yeah.
And that can cause the carpus to shift towards the palm.
Volar translocation.
Yeah, and you can also get ulnar translocation, and sometimes the ulna subluxates dorsally at the DRUJ.
Caput ulnae.
Exactly.
And what about the MCP joints?
So the MCPs often subluxate volarly, and the fingers drift towards the ulna.
Ulnar deviate.
Right, and that's due to a few factors. The radial deviation of the carpus, the forces of pinch, and the weakened ligaments on the radial side of the joint.
And the extensor tendons can slip ulnarly too.
Yeah, that makes the deviation even worse.
And what about the finger joints?
Well, the PIP joints are usually more affected than the DIP joints.
Okay.
And they can develop either flexion or extension deformities,
Right.
like a boutonniere or swan neck deformity.
Right. So let's talk about those classic deformities.
Okay, so the boutonniere deformity, that's when the PIP joint is flexed and the DIP joint is hyperextended.
Right.
And it starts with damage to the central slip of the extensor tendon at the PIP joint.
So the central slip can extend the PIP joint.
Exactly. And then the lateral bands slip volarly, and they end up flexing the PIP and extending the DIP.
Okay. And what about the swan neck deformity?
So that's the opposite. The PIP joint is hyperextended and the DIP joint is flexed.
Right.
And this one can start at the DIP, the PIP, or even the MCP joint.
So different from the boutonniere.
Right.
And how does it work?
Well, if it starts at the DIP, you get erosion of the terminal tendon and a mallet finger, and then the PIP hyperextends to compensate.
Okay.
And if it starts at the PIP, the volar plate gets stretched, and part of the flexor tendon can rupture, and that leads to PIP hyperextension.
Okay.
And if it starts at the MCC, volar subluxation can tighten the intrinsics and cause PIP hyperextension.
And are swan neck deformities more disabling than boutonniere deformities?
Often, yeah, especially when they're stiff.
And what about the thumb? What deformities do you see there?
Well, there are two main types. Type 1 is like a boutonniere with flexion at the MCP and hyperextension at the IP.
Okay.
And type 3 is like a swan neck with hyperextension at the MCP and flexion at the IP.
And what causes those?
They're both due to peroneus and problems with the tendons and ligaments.
Okay, so RA doesn't just affect the joints, it affects the tendons too, right?
That's right. Tenosynovitis is very common in RA.
Tenosynovitis.
Yeah, that's inflammation of the tendon sheaths.
Okay.
And in the wrist, this swelling can compress the median nerve and cause carpal tunnel syndrome. Right. And in the fingers, you can get trigger finger from tenosynovitis or rheumatoid nodules.
All right.
And then there's the Mannerfelt lesion.
Mannerfelt lesion, what's that?
That's a rupture of the flexor pollicis longus tendon in the thumb.
Okay.
And it usually happens from the tendon rubbing on a bony spur on the scaphoid.
Right.
And the extensor tendons can also rupture.
From tenosynovitis.
Yeah, from tenosynovitis and from rubbing over bony prominences.
Okay.
And sometimes the extensor tendons rupture in a specific pattern called Von Jackson syndrome.
Von Jackson syndrome.
Yeah, the small finger extensor ruptures first, and then the ring, then the index.
So it's a sequential rupture.
Exactly.
And how do you know if it's a rupture or something else?
Well, you have to examine the patient carefully.
Right.
Make sure the tendon hasn't just slipped out of place and check for any nerve problems.
Okay.
Yeah.
So we've talked about the joints and the tendons, but RA can also affect other parts of the body, right?
Absolutely. RA is a systemic disease.
Okay, so what are some of the systemic manifestations?
Well, in the lungs, you can get rheumatoid nodules and pleuritis and pleural effusions.
Okay.
And in the heart, you can get pericarditis and myocarditis and even valvular disease.
Wow.
And then there's Felty syndrome.
What's that?
That's when you have RA with an enlarged spleen and a low white blood cell count.
Okay.
And in the eyes, you can get iritis and uveitis and scleritis.
And dry eyes.
Yeah, dry eyes too.
And what about neurologic problems?
Yeah, you can get peripheral neuropathy and mononeuritis multiplex.
Right.
And then there are vascular problems like vasculitis.
And skin problems.
Yeah, you can get rheumatoid nodules under the skin.
Okay, so how do you manage RA medically?
Well, there have been huge advancements in medical management in recent years.
So much better than it used to be.
Oh, yeah, definitely.
So what are the main medications?
So you've got NSAIDs, which help with pain and inflammation, but they don't change the course of the disease.
Right.
And then you've got corticosteroids, which are used for flares. And then the big guns are the DMARDs,
EMARDs.
disease-modifying anti-rheumatic drugs.
Right.
And there are two types, conventional DMARDs, like methotrexate,
Right.
and biologic DMARDs, which target specific inflammatory molecules.
Like TNF-alpha.
Yeah, like TNF-alpha and IL-1.
Okay.
And these DMARDs can really slow down the progression of the disease.
So that's great.
Yeah, it's a big deal.
And what about steroid injections?
Yeah, those can provide temporary relief, but they're not a long-term solution, especially if multiple joints are involved.
Right.
And then there's joint protection and splinting.
So that's like being careful with your joints and wearing splints,
Yeah, exactly. It can help decrease stress on the joints.
but it doesn't stop the disease.
No, it doesn't, and you have to combine it with exercise.
Okay, so what about surgery? When is it indicated?
Well, surgery is not always necessary thanks to those advancements in medical treatment,
Right.
but sometimes it is.
Okay, so when?
Well, generally, we want to try medical treatment for at least 6 to 12 months before considering surgery. Yeah.
Okay, unless it's an emergency.
Right, like a tendon rupture.
Right.
And the main reasons for surgery are pain and loss of function.
Okay.
And the deformities need to be progressive or functionally limiting.
So just having a deformity isn't enough.
No, not if it's not causing pain or affecting function.
And what are the goals of surgery?
Well, the main goals are to relieve pain and improve function and stability and motion.
And can surgery stop the disease progression?
That's debatable. Some people think it can, but it's not the primary goal.
Okay.
Yeah.
So let's talk about surgery for tendon problems now.
Okay, so for extensor tendon ruptures, which often happen in that Von Jackson pattern,
Right.
the treatment is to remove the inflamed tendon sheath and any bony spurs that are causing the rupture.
Okay.
And then you usually need to do a tendon transfer.
Because you can't just sew the tendon back together?
Right, the tendons are usually too frayed to repair directly,
Okay.
so you have to move a tendon from somewhere else.
And which tendon do you use?
It depends on which tendons are ruptured. For example, if the small finger extensor is ruptured, you might move the ring finger extensor to the small finger,
Okay.
and you have to make sure you get a good exposure of the extensor compartments and remove all the inflamed tissue.
Right.
And sometimes you need to do a Darek procedure if the ulna is sticking out too far.
Okay.
And you can put a pad of tissue over the area to protect the tendons.
Okay. And what about the Mannerfeld lesion?
So for that, you need to remove the bony spur on the scaphoid
Right.
and pad the area.
Okay.
And then you can either transfer the FDS tendon to the FPL.
The flexor digitorum superficialis?
Yeah. Or you can use a tendon graft, or you can even fuse the IP joint of the thumb.
Okay.
And for other flexor tendon ruptures, the treatment depends on which tendons are ruptured and where the rupture is.
Right.
If it's in the palm, it's a different problem than if it's in the flexor sheath.
Okay. And what about trigger finger?
So for trigger finger, you open up the flexor sheath and remove the inflamed tissue and any nodules. And for carpal tunnel, you also need a good exposure, and you remove all the inflamed flexor tenosynovium
Right.
to take the pressure off the median nerve.
Okay. So what about surgery for finger and thumb deformities?
Okay, so for swan neck deformities, if splinting doesn't work,
Right.
you can do surgery.
And what do you do?
Well, if the PIP joint is still flexible, you can release the intrinsic muscles and use a slip of the FDS to prevent hyperextension of the PIP joint.
Okay.
But if the PIP joint is stiff, you need to get some motion back first and then treat it like an early deformity.
Okay. And what about boutonniere deformities?
So for those, if splinting doesn't work, you can do surgery.
Okay.
If it's an early deformity, you can just cut a portion of the extensor tendon.
Okay.
But if the PIP joint is droopy and stiff, you might need to improve the flexibility first.
Right.
And then you can do surgery to tighten the central slip and reposition the lateral bands.
Okay. And what about thumb deformities?
So for type 1 thumb deformities early on, you might just need to reroute the extensor tendons. But for more advanced deformities, you might need to divide and reattach the tendons.
Okay.
And in severe cases, you might need to fuse the MCP joint.
And what about type 3 deformities?
So those are treated similarly to arthritis at the base of the thumb.
Okay.
Sometimes you need to reconstruct the ligaments and interpose a tendon.
And if the MCP joint is really hyperextended,
You might need to fuse it.
and if there's a tight adductor pollicis?
You might need to release it.
Okay. And what about MCP subluxation and ulnar deviation?
So if the joint surfaces are still okay, you can do soft tissue reconstruction.
Like what?
Well, you can release or transfer the intrinsic muscles,
Okay.
and you can release or tighten the sagittal bands,
Right.
and you can tighten or reconstruct the collateral ligaments.
And does that work?
It can help, but it's important to remember that these problems can recur.
Okay. So what if the MCP and PIP joints are really arthritic?
Then you have to consider joint replacement or fusion.
Arthrodesis.
Yeah, arthrodesis.
Okay.
Yeah.
So for the index finger PIP joint?
Fusion is usually the best option because of the strong pinch forces.
Okay. And for the other PIP joints?
You have a choice between fusion and replacement.
And what are the pros and cons?
Well, fusion is more predictable and has fewer complications.
But you lose motion.
Yeah, but replacement has a higher risk of complications.
And what about implants?
Well, silicone implants are often used, but other types of implants haven't worked very well in high IR.
Okay. And what about MCP joints?
So for MCP joints, replacement is generally more reliable than for PIP joints,
Okay.
especially if you combine it with soft tissue stabilization.
And what about implants for MZP joints?
Silicone implants are usually the preferred choice.
Okay, so let's talk about the wrist and DRUJ now.
Okay.
What do you do for wrist arthritis?
Well, if the midcarpal joint is okay, you can consider a radioscapholinate fusion.
Which preserves some motion.
Yeah, exactly.
Yeah.
But if both the radiocarpal and midcarpal joints are arthritic, then you usually need a total wrist fusion.
Okay, and what about wrist replacement?
Yeah, that's an option too, but it has a higher complication rate and a higher revision rate.
So when would you do it?
Well, mainly for pain relief and to preserve motion in patients who need wrist motion,
Okay.
like if the other wrist is already fused.
Right.
Yep.
And what about the DRUJ?
So for DRUJ arthritis or capitulinae, there are two main options: the Darac procedure and the Sauve-Capandji procedure.
And what's the Darac?
That's when you remove the head of the ulna.
Okay.
And the Sauve-Capandji, that's when you fuse the head of the ulna to the radius and create a pseudoperthrosis to allow for rotation.
Okay.
Yeah.
So what are the outcomes of all these different procedures?
Okay, so for tenosynovectomy, the main benefit is pain relief. And it might prevent tendon ruptures, but it doesn't affect the joint disease.
Right.
And for tendon transfers, the outcomes vary depending on the pattern of rupture and the severity of the joint disease. And for MCP arthroplasty, you usually get good pain relief and improvement in grip and pinch strength, but the improvement in range of motion is not as good, and you can get late fractures of the prosthesis.
Which are usually asymptomatic.
Often, yeah.
Okay, and what about wrist arthroplasty?
So that's good for pain relief, but it has a high complication rate and revision rate.
Okay.
And it doesn't always improve motion.
Okay.
And wrist arthrodesis is very reliable for pain relief, and it has a lower complication rate than arthroplasty.
Okay.
And for DRUJ surgery, the Darac and the Sauve-Capandji both provide good pain relief, but they can cause instability and loss of strength and impingement.
Okay, so finally, are there any other rheumatoid variants or autoimmune diseases that we should be aware of?
Yes, so there's juvenile rheumatoid arthritis.
Which is different from adult RA.
Right.
Okay.
And then there's psoriatic arthritis.
Which affects the DIP joints.
Yeah, and it has those characteristic nail changes and pencil and cup deformities.
Right.
And then there's lupus.
Which can cause joint deformities, but without joint destruction.
And then there's scleroderma.
Which causes vascular problems and contractures.
Right.
Yeah.
Okay, so to wrap up, what are the key points for surgeons?
So the main indication for surgery is pain.
Okay.
And we don't operate on severe deformities if there's no pain or loss of function.
Right.
And we usually try medical treatment for at least 6 to 12 months before considering surgery.
Unless it's an emergency.
Right.
Oh, wow.
And it's important to consult with the rheumatologist to manage the medications.
All right.
And finally, it's important to remember that RA is common, and we as surgeons might be the first to see it.
In patients with hand complaints.
Exactly.
Okay, well, this has been a great deep dive into rheumatoid arthritis.
It has.
I think we covered everything in a nice, concise way.
Yeah, I think so.
So for all you listeners out there, I encourage you to study hard and good luck on your exams.
Good luck.
And just a final thought as we move forward with all these new medications for RA, what do you think the future holds for surgery? That's a good question. I think it will be interesting to see how the indications for surgery change and what new procedures are developed.
Yeah, absolutely.
Yeah.
Okay, thanks for joining me.
It was my pleasure.
And we'll see you next time.
See ya. Bye.